Good morning, good afternoon. Thank you very much for the invitation. And first of all, to confess that I'm not orthopedic surgeon. I'm just a poor infectious disease clinician plus internist. So I will give you my own perspective after confronting several infections in orthopedic surgery, but not in TSA. So, how do you use this? I will try to answer to 10 questions that I created, and this is really an effort to do that. Why this does not operate? Oh, okay, maybe that way. Okay, which are the risk factors? So we already heard from the previous speaker, but particularly for the shoulder, it's young age, male sex. Why? Because of the greater number of sebaceous glands in men, Cutibacterium acnes, formerly Propionibacterium, you will find in your literature, not anymore Propionibacterium residing in these glands, arthroplasty for trauma and revision surgery, and of course several underlying factors that create immune problems. Which are the definitions? I will skip the classical acute, subacute, and late infection and use what is used nowadays. That means several authors prefer to distinguish between early and late infection with a cutoff of 3 to 4 weeks. And why? Because by using the term early infection, there is a real chance to save replacement of the index prosthesis by avoiding any further delay and without removing the prosthesis. Which are the symptoms and signs? Early infections usually cause local and systemic reactions like pain, draining fistulas, redness, swelling, and of course, if you are dealing with a draining fistula, then you have to go on and operate the patient. However, late infections are usually expressed with pain, without fever and stiffness of the joint, which makes the diagnosis much more difficult. And symptoms may be long-standing, even for several years, and therefore it could be misunderstood. Which are the expected pathogens? Early infections mostly are caused by highly virulent organisms like Staphylococcus aureus or Enterobacteriaceae, which are acquired during or shortly after implantation. In contrast, late infections, and this is a difficulty, are caused by less virulent microorganisms like CNS Staphylococci, Cutibacterium, this is Propionibacterium acnes, and coroniform bacteria. And sometimes, however, by hematogenous spread, we can also confront Staph aureus or Enterobacteriaceae, but that happens more seldom. Although in case of early infection, the implant can remain with a promising prospect of success, late infections usually require replacement of the prosthesis. So now the big questions in your literature and also in my literature. Is Cutibacterium acnes a real pathogen in TSA infections? It seems yes. Why? Cutibacterium acnes is a gram-positive aerotolerant anaerobic bacilli. That means that it creates a lot of problems in the microbiology laboratory and requires a lot of your cooperation. This is an important part of the normal flora of the human skin, living in and around sweat glands and sebaceous glands, colonizing the shoulder at increased rates compared with the knee and hip. This is why we are confronting it mostly in shoulder infections. Men normally have a higher bacterial load than women. And this is why we confront this problem mostly in men, because they do have abundant pilosebaceous follicles colonized the acromial sides. Cutibacterium acnes is difficult to culture. Many infections might remain unidentified for several years, and aseptic loosening of endoprosthetic implants could actually be an infection. So, well, it depends on your reality, on your everyday load, but just think of it. I think this is quite important. And finally, the low microbiological yield in such type of infections is explained by the ability of Cutibacterium acnes to change to the biofilm phenotype as it adheres to the implant surface. And to continue more, just think, and that depends and relates to any kind of cultures in orthopedic surgery in implants. We need 5 to 6 independent specimens. It may take, particularly for Cutibacterium acnes, anaerobic culture for up to 2 weeks. That's a long. Please cooperate with your microbiology lab. And it has been described as the infectious etiology in a wide range, equal or more than 16% of prosthetic shoulder infections and equal or more than 21 of revision shoulder arthroplasty. How it could be diagnosed? Arthroscopic tissue biopsies is a reliable method for diagnosing such infections, and particularly for including Cutibacterium acnes, yielding 100% sensitivity, unbelievable, 100% specificity, 100% positive predictive, and 100% negative predictive value. We have to withhold therapy at least for 2 weeks before taking our specimens during arthrocentesis. A minimum of 4 to 6 periprosthetic intraoperative tissue samples are required, and 2 of them should be positive. And it is suggested that you should get 2 from the joint capsule, 1 from the prosthesis bone interface, and 1 from the medullary canal. Each specimen should be obtained with a different scalp and tissue forceps, which are then immediately discarded. And implant sonication is still very important. Maybe you are quite familiar. We just started working in that field, and it seems this is without sonication, just few colonies, while if there is sonications, then we need more than 50 colonies of Cutibacterium acnes to be sure with what we are dealing. So this is the gram stain, and you have still to cooperate with microlab, not to forget to prepare for you a gram stain. And how to diagnose? People sometimes use also interleukin-6, some other, but this is important only in synovial fluid because that's where you have more sensitive and specific results. And I don't know if you are using alpha-defensin. It is quite expensive, at least in our country, but it has a high sensitivity and a very high also specificity, and particularly 100% negative predictive value. I'm not going to speak about classical radiology. You know better than me all the CT findings, but among scans, I think that labeled leukocyte scan reveals increased uptake in proximal periprosthetic zone of the humerus. Contrary, if you use technetium scan, this is quite difficult to interpret the results and you cannot trust them. So what kind of antibiotics? How to treat the patients? So you have to cooperate again with your lab because this Cutibacterium acnes usually it is susceptible to the classical penicillin G. Who tests nowadays penicillin G? Almost nobody. So it's very important. Amoxicillin, rifampicin, very important because it gets through the biofilm, tetracycline, erythromycin, clindamycin, alternatively vanco, levo, ceftriaxone, linezolid, but resistant by definition, although it is an anaerobic strain, to metronidazole, first and second generation cephalosporins. Therefore, you do not have to use cefazolin or cefuroxime or any first and second generation cephalosporin as perioperative prophylaxis in shoulder surgery. Please, this is a very important point. So we have to administer penicillin G every 4 hours via continuous infusion plus rifampicin, usually for 2 to 4 weeks. And then alternatively, you can use ceftriaxone plus vancomycin, and then oral therapy combinations of amoxicillin, Tectra, Glinda, with rifampicin all the time. But never rifampicin alone, because then you get resistance. Treatment duration, 4 to 6 months. Just a few comments about how to treat Staphylococcal TSA infections. At least in our country, about 35% are strains resistant to methicillin. So if it is susceptible to methicillin, do not forget to use the classical approach that our English colleagues use so often, cloxacillin, 3 grams, times 4 IV plus rifampicin again. If it is Staphylococcus aureus, then intravenous therapy for 2 weeks again, but not cloxacillin. It should be either vancomycin or teicoplanin or daptomycin, again plus rifampicin, because it gets through the biomembrane, never monotherapy of rifampicin, and subsequently combination of 2 oral antibiotics with advantageous kinetics in the bone tissues and the biomembrane, like Glinda, cotrimoxazole, don't forget, almost 100% of staphylococcal strains, at least in our country, are susceptible to cotrimoxazole, minocycline, very important, levofusidic acid, and rifampicin. And what prophylaxis? Well, do not remove the axillary hair, because then you could spread Cutibacterium acnes everywhere in the wound. And people suggest that 2% chlorhexidine glyconate plus 70% isopropyl alcohol is much more effective than the classical iodine preparations. And each shoulder should receive a double skin preparation, adhere plastic skin drapes, and each patient receive preoperative antibiotic prophylaxis with ceftriaxone and vancomycin. Both are required. And finally, maybe you have read that paper. It is from Australia, and there is a colleague of yours who minimizes Cutibacterium acnes contamination in shoulder arthroplasty by use of a wound protector. I don't know if you are. So, to come to an end, conclusion first, just to remind to you that we have to discontinue any antibiotic for 2 weeks before proceeding to surgery and taking at least 6 specimens, and we have to cooperate with microbiology lab for 2 weeks. Cutibacterium acnes is important in late prosthetic infections, mild ones, and also CNS, and the percent is almost similar, up to 20% for each strain. And treatment consists of surgery, mostly 1 stage, plus a combination of appropriate antibiotics. Do not forget PENG, and do not forget to continue with oral antibiotics. In case of staphylococcal infections, again, 2 weeks of IV therapy and a combination of 2 oral anti-staphylococcal agents and surgical prophylaxis. It's very important. Take care to have a good protocol. So, last slide. And now I'm speaking as an infectious disease physician, dear Dr. Levy. Antibiotic stewardship, very important nowadays in all hospitals all over the world. Also in orthopedic surgery, because if I get a nosocomial pneumonia, I can't get treated with antibiotics, but if I get an orthopedic infection, then it's real trouble. And infection control through hand hygiene and contact precautions should go in hand in orthopedic surgery. But please do not forget that cooperation between orthopedic surgeons, infectious diseases experts, and laboratory physicians is absolutely necessary for ultimate success in any orthopedic infection. Thank you very much.